alaikum wa rahmatullahi wa barakatuh. Very good morning to everybody who's watching. This is Stay Healthy, brought to you by Nairobi Neurocare. And today's topic of discussion is epilepsy surgery. And joining me in studio to further this discussion is none other than Dr. Mahendra S. Chouhan. How are you, Dr.?
I'm good.
Dr. Mahendra S. Chouhan. Dr. Today's topic of discussion is epilepsy surgery. And just to start off the conversation so anyone who's listening can understand, what exactly is epilepsy?
So epilepsy is basically, conventionally, we connect convulsion with epilepsy in a way that if someone had convulsions, and convulsions is an abnormal movement which is mostly to and fro happening, and patient mostly becomes unconscious, though it's not necessary. It's an outburst, abnormal outburst of neurons, which is causing some bodily movements, and then followed by unconsciousness. This is called convulsion. So if someone has convulsions more than 3 or more in a year, then the condition is considered as epilepsy, and then it requires diagnosis and treatment. If we can show the computer, then we can show much better. So if you can see that the brain creates some waves which we can see, and these waves, we have a normal pattern, just like we have electrocardiogram for heart, we have electroencephalogram for brain, and it should create certain normal waves. Suddenly the neurons start firing in a very disorganized manner, and so from wherever this outburst is coming, the symptoms will be there accordingly. So if they are coming from the taste area, patient may feel that I am having an abnormal taste in the mouth, or there can be it can start from a facial movement which is abnormal, or it can start with a twitch in the hand, and first in the fingers, then the hand, then the whole arm, and then whole of the body, and then patient can become unconscious. So this is epilepsy. Yeah.
Dr. How is it diagnosed?
So it is diagnosed by EEG. If again I can show my computer. So EEG is done in various ways. Right now in Kenya, there are only most conventional way is there, which is normal EEG, which we call as just the surface EEG. So we put the electrodes on the head, and then we measure it. Now, but there are other advances also which we used to do in India, and I am trained for them. Is something called a stereo electroencephalogram, stereo EEG or SEEG, where in complex cases, because the idea of epilepsy, of EEG in epilepsy is, if you are able to find out an abnormal focus in the brain, and if it doesn't respond to medication, we can do certain things, certain procedures. So we need to map the brain, that from where the convulsion is starting. So this is one of the most intricate way of detecting, say, if your first EEG or the simple EEG is saying it is coming from left part of brain, but which part of the brain we call as temporal lobe or frontal lobe. So it says temporal lobe. Now where exactly in the temporal lobe? So then we have to insert electrodes inside the brain through the help of a robot, and then we can do it. Another thing is we can actually open the brain, and we can put something called a surface electrodes on the brain, and then we can record for next few weeks or next few days, and then we get such kind of reading where this is a normal wave and this is an abnormal wave. So we can very clearly see that there is an outburst, abnormal outburst is kind of an electrical storm coming in the brain, which is then manifesting in the body in terms of abnormal movements and unconsciousness.
Dr. When we talk about epilepsy and the different treatments, let's talk about epilepsy surgery and why epilepsy surgery.
Okay, again my presentation, so I can show. So one of the intricate part, once we have done a complex EEG, sometimes you require a long-term EEG. So we are tuned to doing the long-term EEGs. Of course, it has got some cost implications because patient has to remain in hospital. The idea is to localize from where the convulsions are coming, and particularly for patients who are on medication, still they are convulsing. So if you see, there are several parts, several abnormalities which we can find in brain. We can have extra smooth brain because brain has got a lot of infoldings. So we may have less infoldings, like in this case there is a less infolding, or there can be abnormal focus, there can be a damage in the brain during the process of birth or after a head injury or something. Mostly there are congenital cases where the child is born with the abnormal areas of the brain which cause convulsions. So we do EEG first to localize, then we also do MRI, and in the MRI if we find any particular focus, then we also go for something called PET scan and SPECT scan. We have to do this and then followed by that we go for something called epilepsy surgery. Now you asked why epilepsy surgery. According to international convention, which is now refining more and more, the studies that say that prolonged medication actually damages brain. So if we started epilepsy medication in the childhood, there are very high chances that by the age the patient reaches 50 years, patient has got a lot of neurodeficits or cognitive deficits, they can have walking disabilities, then the cost implications that lifetime of medical therapy is far more costlier than the surgery itself. And then if the patient has got very poor control of epilepsy despite 2 drugs. Earlier it was 3 drugs, but now even with 2 drugs, and even now it is recommended because of a very high success rate of epilepsy surgery. It is even recommended for newborns. So the unit with which I have worked in India, we have operated so many newborn patients if they were born with convulsions and their brain showed certain things. So epilepsy surgery is, again, as you can see on my screen, if we have found, say, an abnormal hippocampus, which is one of the primary areas which causes epilepsy, we can remove only that part, and the complication rates are less than 1%. Success rates are between 60 to 80% in selected cases. So that's why epilepsy surgery should be given to anyone who is surviving on 2 or more drugs, because these drugs are definitely going to cause a lot of problems. It will be far more costlier lifetime, and success of surgeries are very high.
Dr. Harry, I had a question on how safe the surgery was, and you've mentioned if we're already operating on newborns, that clearly states that it is very safe.
Now there are so many cases. I have already published our paper where we have done more than 10,000 surgeries in India on epilepsy surgery, and I have come from one of the world's best centers for epilepsy surgery, where we have actually invented so many methods of correctly detecting the epilepsy, and the work of my former institution is now validated by entire world. So my teachers are now the teachers of the world for epilepsy surgery. So we have published papers and extremely successful surgeries. There are very high rates of, if we have diagnosed them well, there is a very high success rate. We have already done surgeries here, and as I said, that the success rate, the failure rates are, or the rate of complications are less than 1%. The failure rates can be 30%, so 1/3, but those failure rates, we are saying that these patients are still requiring medication, but now their frequency of convulsion is far less compared to only medication.
Dr. Let's talk about surgery as the first option. Would you recommend surgery as the first option when it comes to epilepsy?
No, we don't. Of course, if even if they are very highly successful, we do not take pleasure in cutting the skull. If the patient is, there are very specific protocols, and these are international protocols which we follow. If the patient is very well controlled with a single anti-epileptic, if he's easily controllable, then we don't do surgery. At 2 drugs, we become worried that if patient is taking 2 drugs and still having convulsions, we start finding the cause and the location. Okay, so even for the MRI, we need to have a very specific protocol. Just having a generic epilepsy protocol MRI, which many centers do, does not suffice. It not only requires to be done in a very specific way, there are people who process them in a very specific way. So even that requires a training. Even a radiologist requires a training for epilepsy imaging. So our group does it in India very regularly. I'm very hopeful that from 2024 we are starting training sessions in Kenya for people who can read epilepsy of EEGs and for people who can read the MRIs or their raw data to process from where exactly the conversion is coming. And once we know it's coming from some place, then we would definitely advise when there is a right time to the patient to do a surgery.
And Dr. when you're talking about surgery, how long would it take for somebody to obviously be undergoing surgery when it comes to epilepsy? How long would it roughly take?
So far the surgery that we have done in Kenya, their average hospital stay was 5 days. So we can send them actually earlier, but once the skull is being cut and we have handled the brain, so usually we send anything between 3rd to 5th day, depending upon their recovery. So we're not expecting very long. In fact, again, as I said earlier, that any surgery which is more anatomical, they have got far more better outcomes compared to the tumors, where there can be there can be involvement of an important artery, or there can be compressing the brain, there can be lot of swelling. Those things are not there in such cases. So just like trigeminal neuralgia, which in my past talk I talked that the complication rates are less than 1%, even in epilepsy world over, because of extremely low complication rates, they are actually becoming the primary treatment for epilepsy.
Dr. When we come back, we're going to go on a break. But when we come back, let's talk about who exactly is a candidate for epilepsy surgery. So we're just going to go on a short break, and we're going to come back, and that's the question we'll be answering.
Horizon TV, the beacon for the nation.
Discover a world of learning where the best of American and British education comes together in the heart of Kenya. Welcome to ILM Academy, where young minds flourish and dreams are realized.
ILM stands for Innovate, Lead, Mentor. In our school, we learn Arabic classes and we take also Madrasa classes.
At ILM Academy, we pride ourselves on offering a unique blend of the American and British curriculum, providing your child with a well-rounded education that nurtures creativity, critical thinking, and global awareness.
Our school uses a unique and innovative learning system. There are a lot of favorites I have in the school, but the one thing that stands out the most is playing football with my friends and bonding during meals.
Our experienced and passionate educators are committed to cultivating an environment that sparks curiosity and encourages students to explore the world around them. With the small class sizes, each child receives personalized attention, ensuring they reach their full potential.
We want to excel in education and our religious studies as well. We believe that every child is a holistic being.
But education isn't just about the classroom. At ILM Academy, we believe in fostering a love for learning through a diverse range of extracurricular activities, from sports to arts, creating well-rounded individuals ready to face the challenges of the future. Enroll your child today and give them the gift of a world-class education. Our admissions are now open. ILM Academy, where every child's journey begins.
قال تعالى في محكم تنزيله بعد أعوذ بالله من الشيطان الرجيم
Ninasaha kutoka pwani.
هذا الدين قال الله قال الرسول قال الصحابة هم أولو العرفان انتهى.
Ili kuongoza kwenye njia iliyonyoka.
Sikizeni hadithi hii ya Mtume alayhi salatu wasalam.
Hakuna atakayeweza kumfungia mtu mlango ambaye Mwenyezi Mungu alimfungulia.
Kuimarisha imani yako.
ثبت قلوبنا على دينك وعلى طاعتك.
Ungana na mashekhi wetu kutoka pwani kwenye mimbar.
Mimbar zinamwakilisha Mtume sallallahu alayhi wasallam.
Ni Jumamosi na wakati saa 3 usiku katika katika Horizon TV, runinga uipendayo. Horizon TV, kurunzi ya taifa.
Thank you so much for staying with us here on Horizon TV. The discussion before we went on our break was all about epilepsy surgery. And Dr. Mahendra, the question that I posed to you was, who exactly is a candidate for epilepsy surgery?
So any patient who has epilepsy and it is poorly controlled on 2 drugs, and we can establish something in the brain as a site of epilepsy, are definitely the surgical candidates. Even the patients who have poor control with 2 or 3 medications, we can do some other things if we are not able to find out any specific area which is causing convulsions. There are certain devices that we can put. But usually the treatment of epilepsy, when we say surgical treatment, is always, we call it tailor-made. So each and every individual will have a different area which we need to remove, and that can be done. Of course, there are now minimal access ways also to do the same thing. We can do surgeries with laser only to burn some certain areas, but they still are not very well established because very few centers are able to do them. So the failure rates are higher. So in general, when you start epilepsy program, and we have a pride of starting the epilepsy program in this country, we are still going in a conventional way. So either surgeries or some devices that can be put, and patients can have significant reduction in epilepsy, significant reduction in the dosage of the drugs that they are taking, or in many cases they don't even need a drug for epilepsy surgery.
And so when we talk about epilepsy surgery, are there any specific cases, or does it reach a certain point that you recommend to go for surgery?
No, if there are, as I said, the criteria are very, very well formed. If someone having a problem in controlling the epilepsy with 2 drugs, okay, and if we are able to find out a focus of epilepsy, as soon as we see these 2 things, we highly recommend epilepsy surgeries.
And what is the recovery time after epileptic surgery?
So if it all depends upon when we are operating. Say we have got someone who is convulsing for last 5 years, 10 years, 15 years, maybe 3 to 6 months will be required before we can finally know what exactly is the outcome, because first we will still keep the patients on their drugs after surgery as well, and then gradually we start reducing the drugs, and then we realize that well, there are certain cases where I found that there was a small tumor in hippocampus, and I operated, and then within 1 week I stopped the anti-epileptics, and patient never convulsed for life. So
let's talk about what happens after epilepsy surgery, just to ensure that the patient is recuperating well.
I would like to show my presentation for this to answer. So this is a temporal lobe, and our speech resides on left side of the temporal lobe. Okay, and on the frontal side, which is slightly higher up, there is the speech, in the sense the speech has got 2 components, speaking and comprehension or understanding. So in temporal lobe it's more of understanding, in frontal lobe it's more of speaking. When we are operating such cases, we have to know, like particularly the left side of temporal. In India we have certain systems where we are able to, when we are doing the screening, there is something called a neuropsychological monitoring of these patients, where we locate, suppose patient has got a epileptic area or focus in the area of speech. Then we have, say, I am speaking my own mother tongue, which is Hindi, I am speaking English and some some Swahili. But people who are living here are speaking Swahili, their local dialect and English. So all these three centers can be slightly different. But what is the method by which you will locate such language centers? In India we have it, here we don't have it for now. So when we are operating such areas, there can be a speech issues in such cases. They may not be able to speak well after surgery. This can happen. Or sometimes we have to just disconnect two parts of brain, right and left, because there are some patients in whom the whole of one side of brain is damaged. So then it is causing convulsion, it is also affecting the normal area. So we have to disconnect the two. There is a connecting bridge between these two brains, and we do that. But when we do that, then patient for a time will have weakness of one part of the body. But then those are the cases where they have got convulsions, anything from 15 to 20 per day to even 100 convulsions per day, and they will still keep on deteriorating. So it depends where the focus is, and these patients can have those kind of deficits, but that we discuss very early with patients.
Yes. Once somebody has gone through surgery, are there any chances of epilepsy coming back?
Yes, it can. So as I said, in now if we collectively process the entire world data, we have realized that the good outcomes are between 65 to 80%. But it depends. If someone has got a very small, there are some congenital tumors. I mean, the child is born with the abnormal tumor, but it doesn't grow too much. It doesn't grow fast. So it remains of the same size, but it keeps on giving convulsions. Now, if you remove that, the results are almost 100%.
Yes.
But there are sometimes there are abnormal foci, and then it also depends upon how you diagnosed, because it can be a great processing. So one patient, even if you have a fully dedicated epilepsy unit, it is very difficult to do more than 10 surgeries in a month, because so much of work is required in saying that yes, this particular thing is the focus. Sometimes you can have one focus on the right and one focus on the left part of brain, and you don't know from where. Then you are doing the stereo EEG or surface EEG by doing surgeries. It can be a very cumbersome, but as I said, it depends upon how accurately you are able to diagnose the focus of epilepsy, so we can treat that particular area. But the success rates can be 80%, but 15 to 20% failure rates are still there.
Thank you for that. Now, what are some of the rules when it comes to devices in epileptic surgery?
Yeah, so as you can see in this diagram, now there are a lot of devices. Particularly I would talk about this particular thing, which is a so-called deep brain stimulation. There is something called vagal nerve stimulation. So there is either deep brain stimulation or the device which they detect the epilepsy coming far before they actually manifest in the body. One of the most successful treatment is vagal nerve stimulation, which is not even done in the brain. So VNS is one of the most successful device, although it's very costly. It comes at around $25,000. But if you put that in a vagus nerve, like this particular one, the last one, where there is a device in the under the clavicle, which is a battery, and we have wired the vagus nerve with this device. So what happens that as soon as epilepsy is coming, it is first thing that happens is change of heart rate. If there is a change of heart rate, then if some device can detect it, which this does, which we call as vagal nerve stimulation. So as soon as it changes, there is an increased signal from brain to the heart for increasing the heart rate. It knows that conversion is about to come, and suddenly the battery fires an electric current which goes into the brain, okay, and it aborts the epilepsy. So we have patients where we have put them and who had almost 30 to 40 convulsions in a month are now convulsing just once or twice, and that too they are so mild that patients are able to handle themselves. They are able to control themselves. They are able to brace themselves. Before they just used to fall like a log, and they had multiple head injuries. Now these patients, they are very comfortable. They never had a serious fall after the epilepsy. So these devices are definitely working, and they are reducing the kind of brain dissection that can be done.
Terry, let's talk about what the Nairobi Neurocare does when it comes to epileptic surgery.
So as I said, we already started the epilepsy surgeries here in a conventional way, and now we have got 4 patients lined up for VNS, vagal nerve stimulation. Only thing which limits them is the amount of money that is required, but we have done the logistics, we have done the cost calculations. We have realized that we can do these surgeries at least $3,000 less than India. And also, not to mention, when these patients now get follow-up patients coming from Tanzania and Uganda, where they could go to India for putting the device, and now they can't go frequently because at least 4 or 5 times in a year you require a follow-up and adjustment of device in terms of output, because these are electrical devices. So when we are now, even the companies who have the device, their engineers or biomedical engineers send them to me. So for them to travel from Tanzania to Nairobi is far cheaper compared to India. So overall, the cost of treatment even with devices may be high for a person to afford, but still will be cheaper than India. And we still have a larger group of Indian epileptologists which we can contact, and we can create a good sound decision for our patients based on the EEGs and the specific MRIs that we do, or the PET scan that we do, and then we can do all those things here. We already started it. Now very soon we will be doing the VNS surgeries. So we are actually doing a lot of groundbreaking work so far as epilepsy surgery is concerned.
When you talk about the costs, one of the questions that somebody would probably be wondering or asking themselves is, the Nairobi Neurocare accept insurance?
Yes, we do. There are major insurances that we already cover with, or we work with hospitals which do it. So if a patient comes with us, recently we operated a patient from Kenyatta University. So they have their own scheme, and we operated that, and the university paid us later. So we are working with insurances.
Anything else you'd love to advise people when it comes to epilepsy, epileptic surgery?
I would highly advise that people should consider epilepsy surgery if their patient is not getting good control despite having 2 drugs of therapy. So, but I have also seen that there was some patient who was like, he is a state player for some weightlifting or something. He is like 6'4" and weighs 108 kgs, who was given a pediatric dose of epilepsy tablets, and then he was convulsing. So mere dose adjustments can also do the trick for most of the patients. Right now, about 40% of the patients will require surgery at some point of time. So come as soon as possible, have follow-up with us, because we have a very clear-cut outline when to do the surgeries. We are very well prepared for epilepsy surgeries and device placements. And many people, they just compare the cost from India, which I can say particularly with VNS will be still lower than India. They don't consider the cost that the accompanying person is incurring on their travel. They don't consider the follow-ups, they don't consider the air travel of even the patient, staying there, food and all of those things. I'll give you an example that a patient came to me who had a surgery done in India, and the cost was about $7,000. But when I said, give me the total cost of surgery, the attendance and staying there and waiting for maybe a few weeks so that they don't need the follow-up so early, they said the total cost was $11,000. So I say in $5,000 to $6,000 the surgeries can be done here in this country. So why they are going to India? So for particularly epilepsy surgery, we at Nairobi Neurocare can do most of the things. Follow-ups can be done here, the devices can be brought here. It can be far more cheaper. And now we are getting patients from some neighboring 6 countries. So definitely Nairobi or Kenyans have got a very strong reason to get operated here with Nairobi Neurocare rather than going to India.
And Dr. I thank you so much. I think that brings us to the end of today's show, unless you have anything else you'd love to add before we call it a day.
Just last thing, the Nairobi Neurocare has got an ambition to become the center stage for epilepsy treatment for Africa, because there are about more than 25 million patients of epilepsy, and many of them would require epilepsy surgery, and we are doing it at state-of-the-art level. We have already started doing it since last 3 years. We are operating patients. So we would request that you trust Nairobi Neurocare, and you also take into consideration the ease of follow-ups, so that you can get far more effective treatment in Nairobi from Nairobi Neurocare.
Thank you so much, Dr. Mahendra. I think that brings us to today's topic of discussion. Thank you so much for staying with us here on Stay Healthy. Until next time, goodbye.
Horizon TV, the beacon for the nation.
Magic has hit your imagination of TV. A brand new Vitron TV with StarTime's inside technology. New TV innovation with an inbuilt decoder that connects you to both StarTime's antenna and satellite signal. With StarTime's inside Vitron TV, you can enjoy over 200 local and international channels. 1 month StarTime's highest bouquet for free. Automatic system update. More benefits, more affordable. StarTime's inside Vitron TV is available in all StarTime's branches and dealers countrywide. StarTime's inside. Entertainment inbuilt.
StarTimes.